So today we are mainly going to deal with abdominal radiography, and we have to understand how exactly an X-ray works. Okay, so first thing is, it is very simple. There is an X-ray source here. From this X-ray source, the X-ray comes and it will hit the detector here. So this film is normally having some bluish tinge, bluish to white tinge. Now, whenever X-ray hits it, it turns black. So that means whenever X-ray hits a film, it becomes black. So this just tells us that the basic X-ray, the non-exposed X-ray, is almost bluish in color. It will turn black when X-ray comes and hits it. Now, how these images are formed? The X-ray comes and hits the film. The what makes the difference every time is the contents that are present in front of it. Sometimes there can be a solid brick here, or there can be some liquid component here, or it can be something like a soft tissue can be present here. So the various things can come in between. Now, what can stop the X-ray the most is some things like the metal. A metal can stop the X-ray the most. Okay, and then if you compare it to the air will not stop the X-ray at all. What does that mean? Whenever there is air, more X-ray goes through it. Whenever there is a metal, very less X-ray goes through it. Now, in this pattern, if you see bone in our body, there is bone which is very dense, or sometimes there can be some implants. Okay, in the body, there can be some implants can be present, or there can be bone. These are the ones which have maximum attenuation of X-ray. It will stop the X-ray the most. So how does the film appear here? It will appear more whitish or bluish in color. Okay, so that means that we know that whatever white things that we see in this X-ray are the ones that are stopping the X-ray the most. So we know that this is bone. So that's why it is looking white. So these are the ribs, which is made up of bone, and that is stopping the X-ray a lot. So that's why it's looking white. Also, there are some structures here that are looking white. This is nothing but the liver shadow here. And similarly, here we can see the splenic shadow. Okay, again, if you go in depth about it, will also, it is not only dependent on what all attenuates. In olden days, it is just about allowing the X-ray to pass through the body, and then it will go and hit the film, and that's how we get different colors. Now it's not like that. Even after getting an image, we can change the image and we can modify the image. The same like how we take a photography. We take a photograph at any particular location. We don't bother too much about the light settings, but later we can make it more brighter, less brighter. Similarly, nowadays X-ray can be done more brighter and less brighter. We can change the window settings and all that. So that is not important for us. Now, what becomes important is, as I told, whenever there is bone, the X-ray appears white. Whenever there is air, the X-ray appears black. Okay, so this is what we had learned even in the chest X-ray part. So that's why I just put a chest X-ray image. And in between, there will be soft tissue that will be having a slightly whitish in color because it is stopping some of the X-rays. And if you compare soft tissue with fat, now we know that the fat is less denser than soft tissue. So it will not stop the X-rays as much as a soft tissue. So what should be the brightness of the fat compared to the soft tissue? If you can answer in the chat section, if anyone is interested, you can do that. I'll be keeping the chat section open. So whenever fat is present and soft tissue is present, and X-ray is passing through both of it, and they both forms a film, which will cause more whitish image. That will be usually a fat. Why fat? Because the fat is less denser, it will stop less X-rays. Okay, now if you see whitish will be usually bone or calcification. Okay, so there is some doubt. Someone is asking why liver and heart is more radiodense than ribs. See, now one more thing we all have to understand is, okay, what we have to understand is, now there is some tissue. Okay, consider this is soft tissue. Okay, now consider this is bone. Okay, here it is bone. Now I'm allowing 100 x-rays to pass through soft tissue. Consider it has allowed 50 x-rays to pass through it. Okay, so that is a soft tissue. Now in the same time, now here there are 100 x-rays, they are going and they are passing through the bone, and bone will allow only 10 x-rays to pass through it. Okay, so that's why we know that the film here looks more white and film here looks comparatively less white. Okay, now imagine I keep one more layer of soft tissue now. Okay, I kept one more layer of soft tissue. This is just both are soft tissue. Now what happened? I had passed 100 x-rays, 50 came out. Now this will again allow only 25 x-rays to pass through. Now imagine if I keep one more soft tissue component, it will again divide it, only 12 x-rays to pass through it. Now if I keep one more layer, it is allowing only 6 x-rays to pass through it. When this happens, now see which allows more x-ray to pass through it. So it is not only dependent on the density, it is also dependent on the thickness of the tissue. The liver is much more thicker compared to the ribs. The heart will be much more bigger compared to the ribs. So this is again very important doubt. It is a very good question that you asked. So this is also to be understood. The density, the whitish appearance also depends on the thickness of the tissue, also with the density of the tissue. That is one thing to understand. Now in this, what we have to observe is, now whenever an x-ray, chest x-ray is taken, what they do is they make the setting such a way that air is very enhanced. Okay, whenever we take a chest x-ray, the air is very enhanced in it. So that's why we see this chest x-ray, the air, the lung looks very blacker, even though there is lung, but inside the lung there is air. So because the settings are such a way that air is seen very prominent in a chest x-ray, and that's what we have to study in a chest x-ray. We have to see where there is air and where there is no air. That's what we have to see. So that's why we have done the setting such a way that the lung looks blacker because of the air. Okay, so that's one more thing that we have to keep in mind. I'll tell you why this point becomes important in an abdominal x-ray. Okay, now let's go to an abdominal x-ray. We saw that whatever that looks white can be bone, can be something like calcification. Again, it will be denser, so appears white. Blackish color is usually seen because of air, and soft tissue will be somewhere in between white and black, that is grayish appearance. Now, whenever we see an abdominal x-ray, the main advantages is we can see air very clearly. Because we can see bowel obstruction and we can see stone. The disadvantages of the abdominal x-ray includes we cannot do it in the pregnancy. Okay, in a pregnancy, we cannot do an abdominal x-ray because there is a risk of radiation there. Also, the soft tissue delineation is not that good. So one more thing that I want to add on here is in any x-ray, the densities that we'll be able to see are, it's bone or metal. After that, we can see soft tissue density. We can see water density. No, usually, sorry. So we can see bone or metal. Then we can see soft tissue or water. We cannot easily differentiate a soft tissue and water density because of very small difference in their attenuation value. We cannot differentiate a soft tissue and water usually in a chest x-ray. And then we can see fat, and then we can see air. So if we say, if you consider all this, it can be bone, metal, bone, soft tissue and water, fat, and air. Only these densities we can see. We cannot even differentiate a soft tissue from water. We cannot differentiate different types of soft tissue. So this is what makes it very difficult to understand some of the point that we want to know that's happening inside. So these are the disadvantages. And when do we do abdominal x-ray? Whenever the patient is having pain abdomen, one of the things, what are the things that we suspect? We can suspect there can be it can be a mild gastritis, which can be treated with simple gastritis medication, or it can be as severe as perforation of the bowel, it can be obstruction of the bowel, and so on. So whenever we suspect something like perforation or in the bowel obstruction, this becomes very handy and we can diagnose it. Stones and masses are not usually diagnosed with abdominal x-ray, but sometimes incidentally, if you see, we can even evaluate that. Good. iPad 6 has answered that we can see intestinal obstruction, intussusception. Yes, all these conditions can be seen in a abdominal x-ray. Again, contraindications will be pregnancy. Whenever we suspect pregnancy, we should always avoid an x-ray or a CT examination unless it is life-threatening. And whenever it is a life-saving situation, even x-ray can be done on such patients, even if they're pregnant. Okay, so that one thing should be kept in mind. There are a lot of times we see that there are a lot of it will cause problems in pregnancy, but as long as the mother is alive, you get an abnormal baby. But whenever it is a life-saving investigation, so we can always do an x-ray without any hesitation. Okay, now this is how a normal abdominal x-ray looks. Now if you see this carefully, if you see the large intestine, now this area, so what is the indication of abdominal x-ray in pregnancy? So if in case you are suspecting there is a perforation of the bowel in a pregnant woman and you want to emergently take for a check for the perforation, you don't have any other modalities, then you can just do a chest x-ray. And okay, again, why I said chest x-ray in perforation, I'll tell you that. Okay, so whenever you suspect a perforation, you can do a chest x-ray to see for the perforation of the bowel. Okay, so that becomes an emergency, because if you let it continue, then the patient is going to die of peritonitis and sepsis. If you do a simple chest x-ray and get a diagnosis of perforation, then you are saving the patient. Okay, so that doesn't happen every time, but you can use it whenever if it is a life-saving. This is not only holds good for x-ray, it can be even for CT. Okay, whenever you're suspecting a intracranial hemorrhage, or you're suspecting a stroke, we can again don't have to think twice. Okay, what if she is pregnant? We can always go ahead with the CT head. So whenever we are dealing with radiation, it is the hazards of the radiation is kept in mind only when it is not an emergency. But if in case a life-saving situation, we can always use it. Okay, that's what we have to understand. Now, this is how an X-ray abdomen looks. And if you see in this area, we can see something that is going, some air column, patches of air column that is going linearly in a horizontal, in a vertical manner. And similarly, we can see some air column in this area also in a vertical column. Now, air column in large bowel can be commonly seen. Okay, but continuous air column in the ascending colon, transverse colon, and descending colon should be little suspicious. Okay, so now this is how we can delineate. So this is an ascending colon, this is a transverse colon, and then this is the splenic flexure and descending colon, and this is a sigmoid colon, and it forms a sigmoid. Okay, so this is how we can see the bowel. And very important point that we have to observe is that this large bowel is having multiple haustras, and they are placed far from each other. This haustra here, this indentations here are placed far from each other. So that's what is normal appearance of a large bowel. Okay, and large bowel has an ascending colon, transverse colon, and descending colon. And this is how it is arranged, and this is how where we see. This is how the normal appearance with horstrations, with septations. And if you see this here, this shadow here is nothing but the liver shadow. And here the shadow is the splenic shadow. See how small the splenic shadow is. Imagine if the spleen is seen as big as the liver, that means that spleen is enlarged. But this we don't routinely do to just check the spleen. But if you see in the abdominal X-ray, it's good that if you pick it up. Okay. And here we can see the vertebral bodies. So this, the lowermost vertebral body will be the L5 vertebral body. This will be the sacrum S1 vertebral body. So this will be the iliac crest. And so this is L4, L5, sorry, L4, L3, L2, L1, and this will be the D12, that is 12th thoracic vertebral body, and this will be the 12th rib. Okay, so these are the structures in general that we see. And if you observe, the large bowel is almost forming like a lining on the outer aspect of the abdomen. Okay, now this inner aspect, whatever the shadow we are seeing here, are because of small bowel. So whenever we see a small bowel pathology, it will be in the inner aspect. Whenever we see a large bowel pathology, it will be somewhere in the outer aspect. And even in this area of small bowel, normally we know that the duodenum forms a C formation, and the fourth part of the duodenum will continue as the jejunum, and the jejunum will continue with the ileum, which continues with the large bowel. So if you divide this entire abdomen, the left upper quadrant is made up of jejunum, the right lower quadrant is made up of ileum. So any pathology related to jejunum will be seen in the left upper quadrant, whereas any pathology related to ileum will be in the right lower quadrant. Okay, so this is how we have seen the abdomen and various structures there and how we suspect a pathology. Now I will mark a structure. If you can see that, can you tell me what it might be? You can see a shadow here. You can see a shadow here. You can see a line here and a line here. Now, what this structure might be, according to you? Come on, iPad 6, you have been very active. So, yeah. So, ureter, you're telling it is ureter. Okay, good. It is a good guess because ureter also goes somewhere from there. Now, what if I point out to you something? It is going in an outward direction and it is meeting the vertebral body somewhere here. See, if you see, it is seen almost from here and it is running, and it is equally dense on this side, and we can see just one line on this side. So this is a structure that is passing like this. Now, if you can guess what it is, good. It is not a psoas abscess. So see, why did you call it a psoas abscess? Maybe you saw these air pockets, but they are normal bowel. Okay, even normal bowel can have the air pockets. It is a psoas muscle. Yes, good. It is a psoas muscle. Okay, Avinash Mukherjee has answered. Okay, it is a psoas muscle. Now, see, now what you have to observe is you can see that it is a linear structure which is going and joining almost in the medial 1/3 to mid to medial 1/3 of the iliac crest. Now, this structure going in a linear fashion is nothing but a psoas muscle. Now, imagine if it is going this way and you are seeing a bump and then going down, then what it can be? Now we can think of all this. It can be psoas abscess. What else can it be? What else can it be? I'll give you a situation. The patient is on multiple anticoagulants. Patient is on antiplatelets. Yes, good. It can be a hematoma. Okay. So if you see a bump here, it can be hematoma. And see, these are all sequelae. A patient on antiplatelets, anticoagulants can spontaneously bleed and he can have a hematoma. Whenever there is an hematoma chronically left to be there like that, it will act like a culture media, and there is no immunity that will be acting inside it because it is just a collection there. The immunity is there in the blood vessels, which is not there. Eventually will get infected. Now, how do I know that there is an infection? I see a bump here. I see a few air pockets in that area. That's when you suspect a psoas abscess. Good IPAD 6 thought of psoas abscess at that moment. Now, one very important question here is why there is a line seen. Okay, why did we see a line? We are not, see, we saw liver border here clearly. Okay, we saw the liver border clearly, but on the lateral aspect we don't see the liver border. We till the end, till the surface of the skin, it is like one density, because soft tissue and liver are of same density. They're all soft tissues, so they are all looking like one. But why is this psoas having this line, and why is this psoas is so clearly delineated? What is delineating the psoas there? Can anyone think of it? This, I am just triggering some thinking planes. See, intermuscular plane. IPAD 6, good thinking, but what did I tell first? The X-ray is very bad to delineate different soft tissue. Okay, it cannot differentiate one muscle from the another muscle. Okay, so there should be something that is making it look more blacker. See, why we are seeing this line is not because of the muzzle alone. It is because you are seeing something which is more blacker. Okay, what do you mean by areolar tissue? Okay, IPAD 6 is telling it is because of areolar tissue. What are you thinking there? Yes, it is the fat. The retroperitoneum is filled with fat. Okay, any structures in the retroperitoneum will be surrounded by fat. So not always surrounded, there will be fat. It depends on person to person, depending on how much of the fat is there in that person, it will surround the structures. So that's why, because of the fat, we can see that there is one line, that slight blackish color is because of slight lower density of the fat, which is making us slightly obvious of this line. Okay, similarly, why are we seeing liver lower surface? It's not only because there are some fat, it is also because the bowel is filled with air. Now, whenever the bowel is not filled with air, sometimes it makes it difficult. See, in this image, we can see that the liver is somewhere here. Okay, but we cannot differentiate the outer surface of the colon. If you see in this image very clearly, we can see air here. This is the blackish color is air. Now, just outside the blackish color, we know that the inner surface of the colon, we can see that there is a curved structure that is nothing but the inner surface of the colon. But try to trace outside that. If you trace outside that, are you seeing the border between the liver and the colon? Are you seeing the border between the liver and the colon? You're not seeing the border between liver and the colon. Why? Because both are soft tissue. Now, imagine if you see the border between liver and the colon, what are the possibilities? If I'm seeing the border between liver and the colon, what are the possibilities? Okay, just think about it. If you see the border between liver and the colon, what are the possibilities? No, hepatomegaly just means that liver has become bigger. It has pushed the colon down, but the colon is still touching the liver. Colon is still touching the liver. So you are not supposed to see the border of between the liver and the colon. Okay, so even liver comes in front of the colon. If it is touching the any of the part of the colon, we cannot see. Good. If in case, Avinash Mukherjee is telling, if in case there is a perforation and the air has leaked out of the colon, and if it goes in between the liver and the colon, we can see a border. Very good thinking. Now, this holds good for the entire abdomen. Okay. Now, any structure that we see in the abdomen is nothing but air. Okay. Just keep in mind one thing. X-ray abdomen is all about air. CT abdomen is all about seeing the fat. Okay. This is very important. Whenever you see an X-ray abdomen, always look for air. Whenever you see a CT abdomen, always look for a fat. Okay, fat will give all the answers in CT. Air will give all the answers in an X-ray. So if you see this air, whatever we are seeing, this blackish appearance is air. Now that is always seen in the inner aspect of the bowel lumen. So any air shadows that we are seeing are the inner aspect. Whenever the air goes outside, we can see a thin wall of the bowel loops. So very simple understanding here. Whenever you see both the surface of a bowel in an X-ray, that means there is some air outside the bowel. Other than perforation, can you think of a condition where there is air outside the bowel? Just to make you think, I'm asking this question. Can you think any condition where you can see air outside the bowel? Okay, so if you can answer there. Necrotizing enterocolitis, you can have the air within the bowel. When it perforates, it goes outside the bowel. Pneumoperitoneum, most common cause is pneumoperitoneum. Nothing means, just tells that air inside the abdomen. That happens during the perforation as well. But one iatrogenic cause will be there. If the patient has been operated, sometimes there can be little bit air within the abdomen for some time because of the surgery. They have opened it up, the air is there, but this will not be, this will be absorbed very soon, and we will not see it for a long time. Whenever we see perforation, always think of whenever you see a pneumoperitoneum, always think of perforation. And pneumoperitoneum just means that air inside the abdomen. Okay, inside the peritoneal cavity, if there is air, that is called pneumoperitoneum. That is not a condition, that is just a terminology. It can happen by different conditions, different causes. Okay, now here also we can see air and the lining outside. So this is again a colon. Now if you see the similar air in the middle of the abdomen, that will be because of the bowel. Now if you all think of it, we are not seeing much of air in the small bowel, but we are seeing a lot of air in the colon. If you think why, can anyone tell why the bowel in the small bowel is not usually, does not usually show the air gas shadow? Can anyone think of it why the small bowel does not usually show gas shadow? Yes, good. iPad 6 is telling it's because the small intestine has lot of secretions. Good. The small intestine is usually a secretory organ. It will be secreting a lot of, it is getting a lot of secretions from the liver. It is getting a lot of secretions from the pancreas, and the small bowel itself will have a lot of secretions. So it will be always filled with the fluid. When this content goes to the large intestine, the job of large intestine is to absorb the fluid out of it, and there will be microorganisms. The food is acted upon by the microorganisms in a long run, and that's when the air is produced. That's why usually we see air in the large bowel. Less commonly, we will see air in the small bowel. So whenever we see a small bowel, prominent small bowel filled with air-filled small bowel, we should always have some suspicious in mind, some suspicion. There are a lot of air in the small bowel. Always think there might be something wrong. Okay, so that's how we have understood the abdominal X-ray till now. Now, what is the step one in an abdominal X-ray? As I told before, the step one in an abdominal X-ray is nothing to check the gas pattern. So stomach is usually filled with gas because we swallow a lot of air. So that's why stomach is usually filled with gas. Okay. If you see the small bowel, we'll see at only 2 to 3 pockets of air might be present, because as we discussed, there will be a lot of fluids. And large bowel, usually the rectum and sigmoid colon, as you go more and more distal, it will be filled with air, gas, and it depends on how long the period of the contents are present in the bowel. Based on that, the gas might be present in the other parts of the colon. But usually, in an entire abdomen, you are not supposed to see more than 3 pockets of air fluid levels. Okay, you are not supposed to see more than 3 pockets of air fluid levels. Okay, after the step 1, you saw the air patterns. Then you have to see the size of the bubble. Okay, if you see the small bubble, it will be around 3. If it should be less than 3 centimeter, if it is more than 3 centimeter, it is abnormal. Large bubble more than 6 centimeter, it is abnormal. Cecum more than 9 centimeter. 3, 6, 9 is what you have to remember. Now, when will the bubble dilate? A very simple answer. Whenever there is an obstruction, if this is the lumen, if there is an obstruction at this level, the food components, the secretions will be coming, and that will be loaded here, and it will start dilating. So whenever we see a dilatation of small bowel alone, only small bowel is dilated to 3 centimeter, that means that the obstruction is somewhere before the ileocecal junction. That means only small bowel has been obstructed. But if you see that even the ascending colon, the transverse colon are also dilated more than 6 centimeter, that means that the obstruction is somewhere maybe at the descending colon, rectum, or the sigmoid. Based on what all structures are dilated, we can think of it. Okay, so this is how the size will help us. Okay, now going on to the small bowel obstruction. Now only one question: is this X-ray normal? Very simple question. Is this X-ray normal? Come on, you can answer. If it is normal, you can tell why. Yes, if it is abnormal, you can tell it is A. Okay, now what we are seeing here, this structure is nothing but the air in the fundus of the stomach, and there is fluid here. So this, whenever we see a straight line anywhere in an X-ray, that means that there is an air fluid level. Good, Tejasvi Patil is telling there is more than 3 air pockets in. It is not exactly air pockets, Tejasvi. Sometimes we will see more than 3 air pockets also. But if you see more than 3, this pattern, so why is this air fluid pattern? Can anyone tell why is this air fluid level? Why didn't I call other shadows as air fluid level, but why is this shadow being called as air fluid level? What we are seeing classically here, which we are not seeing in the other place, is there is a horizontal line that is separating the meniscus from a clear horizontal. Good, there is a clear horizontal line separating the air. Okay, so this is a clear horizontal line is separating it. So you saw this here. You're seeing it here again. And if you see here also, you can see here, you can, if the light, you can see multiple air fluid levels. Okay, you're seeing now only one simple question: is this patient in a supine position or an erect position? Okay, based on this X-ray, can you tell, is this patient in a supine position or an erect position? Okay, so iPad 6 is telling is an erect position. Samar is telling it's erect position. Yes, it is erect position. Why? Because all the fluid has collected down, air has gone up. Now, if you have to see this pattern, then the patient has to be in erect position. Okay, so good, gravity has pulled the water down, air is remaining up. So if you have to see this pattern, then the patient has to be in an erect position. So the moral of the story is, if I have to see this air fluid level, the patient has to be erect abdomen. So will I be able to see a air fluid level in a supine patient? The question now is, will I be able to see an air fluid level in a supine patient? Supine patient X-ray is coming from above and going back. The patient is lying in supine position. Will we be able to see this position? No. Good answer. So what does that tell? Whenever we want to comment on air fluid level, always take an erect abdomen X-ray. Sometimes the patient is in such a bad condition, you cannot take an erect X-ray. What else can you do in this patient? Whenever you cannot take an erect, you cannot make the patient sit. He cannot get up from the lying down position. Huh? Good. We can take a lateral X-ray. That's when we'll see the fluid level at one towards the gravity, air on the anti-gravity side. So whenever we see this air fluid level, multiple air fluid level, that means that we will be seeing we are seeing the obstruction, and whenever there is an obstruction, it should be seen, we should be do an erect chest, erect abdominal X-ray. Okay, so that is one thing that has to be kept in mind. Now, one more very important point what I wanted to tell was, so why there is air fluid level. Now, whenever there is no obstruction, the fluid is easily passing, the gas is easily passing. Now, whenever there is an obstruction, the fluid content is there, the fluid is getting accumulated. Whatever the air that is swallowed is also not passing through the bubble, it is staying there. Also, the organisms can act on it. It can produce some amount of air there. Now, that is what is leading rise to formation of the menisci of air, and the secretions that are present there will form the fluid, and that's why we see this classical air fluid level. More than 3 air fluid level is always abnormal. 1 air fluid level here, 1 more air fluid level at the duodenum, and 1 more air fluid level at the level of cecum are normal. 1 in the stomach, 1 in the duodenum, 1 in the cecum. Normally, these 3 places we can see sometimes in the duodenum, mainly in the cap of the duodenum, because of their the large shape, the round shape, the stasis can happen sometimes, can give rise to air fluid level, air fluid level, air fluid level. More than 3 air fluid level or air fluid level anywhere other than this in the bowel is always abnormal. That has to be kept in mind. Now, how do I tell that this is a small bowel? Okay, now I am telling that this is a small bowel. Now, I am telling this is a small bowel. See, if you see at this area, we can see multiple valves here. It's a valvulae conjunctus. Now, these valves are very closely placed and continuously present. What we call as a spring appearance is seen in case of a jejunum, whereas the haustres are more farly placed in case of a large bowel. Okay, large bowel, there are haustres which are placed far from each other, whereas the valvulae conjunctus are closely spaced present in the jejunum. So this is one more example where we can see there is a linear line here, 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 there is a linear line here. More than 3 air fluid level. Very simple diagnosis of obstruction. Now, what do you think is the diagnosis in this? And what do you think is the position of the patient? What is the diagnosis in this? We are seeing the small bowel loop is filled with air and dilated with air. Now, what might be the diagnosis in this? What is the diagnosis here? Come on, you guys know it, just answer that. Okay. And what is the position of the patient? Good, even this is intestinal obstruction, but why am I not seeing the air fluid level in this patient? But I am just seeing the air. I can see the air here. I can see multiple loops of air. Okay, I'm seeing multiple loops of air. Why am I not seeing air fluid level here? Good, you guys are thinking very well now. Come on, try answering this as well. The patient has not eaten. Okay, that's a very good answer. Even though patient has not eaten, the body, the intestine will be secreting fluids. Even if there are liters of fluid that is secreted by the intestine, where has that fluid gone here? The answer is here actually. The patient is in supine position. Good, Avinash Mukherjee is telling the patient is in supine position, and it is not a normal X-ray because you're seeing a prominent air shadows here. And also observe that the distal to the small bowel. So whatever we are seeing here is a dilated small bowel loops. If you measure at some areas, if you see the size, it looks almost the size of the cecum. The cecum is usually present here. Now this is how big the small bowel is looking. So this, I told you that time, whenever the bowel is filled with air, think there might be something wrong. Not always, but there might be something wrong. But in this patient, we are not seeing ascending colon, we are not seeing descending colon, we are not seeing any air shadow here, no rectum, no sigmoid colon. That means that there is some cutoff that has happened. So beyond that, everything is collapsed. There is ascending colon, transverse colon, descending colon, the sigmoid, the rectum, everything is collapsed. It's completely collapsed. There is no air, there is no fluid, nothing. But if you see the proximal bowel, there is dilated and congested bowel. This is also a case of obstruction, but the patient is in supine position. What happens when the patient is supine position? When the patient is supine position, okay, consider this is the head of the patient, this is eyes, okay. Now this is the patient. Now there are like multiple bowel lobes. Now the fluid is here, which is accumulating in the lower half within the bowel, okay. It's within the bowel, the fluid is within the bowel, but it is in the lower half. X-ray is taken in this direction. The fluid is distributed uniformly everywhere. We cannot see the fluid component because it is just giving a haziness to the entire bowel, but the air component is making the bowel looks more blacker. So we are not seeing the air fluid level now. But the same condition when the patient was erect position, now the bowel loop was this way. Now what was happening? At this loop, the fluid was accumulating here. This loop, the fluid was accumulating here. Here the fluid. Now when you're taking X-ray here, it looks black. When I take X-ray here, it looks white. Here it is white. Here it is black. So that's why we saw the air fluid level. In a supine, we cannot see the air fluid level. This is one more example. And why did I call this a small bowel? We can see this closely placed valvulae conjunctis, which is not seen in the small bowel, and what we call it as a coil spring appearance classically tells that it is a small bowel. Now, can anyone tell me what are we seeing here? Can anyone tell me what are we seeing here? Just there is one huge bubble of air here. There is one more huge bubble of air here. Rest of the abdomen is again gasless. Good. Ashmita Jain is thinking that there are only two air shadows. Maybe it is a pyloric stenosis. Good. But why there is a second air bubble there? Okay, why there is a second air bubble? And one more thing, pyloric stenosis can allow air to pass through it. Okay, it can allow air to pass through it. So good. It is double bubble. Siddharth Agarwal is seeing double bubble appearance. Good, Avinash Mukherjee. There is a duodenal atresia. So when the distal part of the duodenum is atresia, the jejunum will not be seen. Air is not going into the jejunum. Air is not going into the small intestine. Air is not going into the colon. There is no food is also entering there. Everything is accumulated here. So there is this stomach and there is this duodenal bulb that is appearing here. So this is double bubble appearance, classically seen in duodenal atresia. What are the other conditions that can show this are a tight annular pancreas. Very tight annular pancreas can show this. Or sometimes there is malrotation of the duodenum, the twisting of the duodenum, the second part of the duodenum also can cause complete obstruction of the proximal duodenum and the stomach, giving this classical double bubble appearance. Duodenum and stomach, this is what is seen, and this will be seen in the fetus because in the neonate. As soon as child is born, you can see this, and it can also be seen in case of in the fetus when you do an antenatal ultrasound. What are we seeing in this image? Now we can see that there is some bowel loop which is touching the surface of the abdominal wall. and it is just going in this fashion, and it is going down till here. We can see it is going down until here we can see. Now what is this bubble loop? So this is nothing but a large bubble. So why, what are the points that are telling us they're large bubble? We can see that there are house trays that we can see. There is the constrictions that are placed far from each other. So we can see the constrictions here that are placed far from each other. Okay, so this is what tells us that this is a large bubble. And normally the ascending colon goes like this, and normally it forms a loop like this and forms a descending. But because there is obstruction, it has formed a loop of itself here, and then it's going almost into the splenic flexure, and we can see almost till the descending colon. So this is nothing but the dilated large bubble. Okay, the haustrations are seen even in the lateral aspect, but they are not that obvious because it is over distended bubble. The bubble is distended too much, but we are seeing some amount of constrictions here. So that is what we see in case of a large bubble obstruction. So this is again one more case. This is a cecum which is grossly dilated. We can see here also completely filled with air, the large bubble, because of the obstruction. We can see here the haustrations again. Okay, now what are we seeing here? We are seeing there is some part of the bubble that is dilated, having coffee bean appearance. Coffee bean appearance is nothing but a bubble which is supposed to be like this. It has folded itself such a way that the two walls are touching each other, making the central sulcus. The outside, it is nothing but the bubble wall. So that's what is making the coffee bean. But there is one point there, the ends of these 2 points are constricted. And why are constricted? Because they are twisted around each other. So they are twisted around each other. So this is nothing but this kind of appearance seen in any long bubble when it twists itself. So this is nothing but, so we see that the pedicle of this is towards the left hip. So that, and the bubble is almost going this pattern. So if you see the previous image, what bubble goes here like this? So that is nothing but the sigmoid colon. So whenever there is a sigmoid volvulus, there will be an air-filled sigmoid colon forming a coffee bean appearance, going from left lower quadrant, because that's where its mesentery is attaching it, and the free margin goes towards the opposite side. Now, similarly, if you see this image, it is pointing towards the right lower quadrant, going towards the left upper quadrant. So this is nothing but the sigmoid volvulus. So these are the two different volvulus that we see. Now, in this image, so this is a colon that we are seeing. Now, if I tell that this is a transverse colon, what we are seeing, what has happened to the haustrations here? What has happened to the haustrations here? Can anyone tell what has happened to the haustrations? The haustrations, the indentations have become more thicker. Now, what are the conditions that can cause this? Now, what are the conditions that can cause this? So, cecal volvulus. Okay, so the last image that we saw is the cecal volvulus. Okay, so this is the cecal volvulus. Sometimes the cecum is the entire transverse colon, ascending colon, descending colon, or retroperitoneal. The cecum is the part of the cecum is not retroperitoneal. So whenever there is constipation, this becomes very, this gets enlarged, then it starts twisting on itself. Even the part of the ascending colon twists there, and that's when we get this kind of appearance. That is nothing but the cecal volvulus. But whenever we see a coffee bean appearance, usually we think of a sigmoid volvulus. So, but always know, keep in your mind that there can be cecal volvulus as well. Okay, so now if you see in this image, we can see this is nothing but the transverse colon. We can see the haustrations here. Now, thickening of these haustrations are seen in pseudomembranous colitis because of the membrane formation there, or whenever there is an edema, this thickening can happen. What are the conditions that can cause edema. Whenever there is ischemia, block in the blood vessels or venous block, arterial block, there will be edema, which will be causing it thickening, or inflammatory bowel disease sometimes can causes. This classical appearance is called thumbprint sign. So this is edema. This is not necrosis. Himanshu, when necrosis is there, there will be the tissues will undergo the maceration. There will be infections entering there. So there will be some air components also entering there, and that will be similar picture to the necrotizing enterocolitis. Okay, so very important question. If whatever we diagnose till now is the step one, if you miss the step one diagnosis, the patient will come to this. And what we are seeing in this image, if anyone can identify, what we can see here, this is the diaphragm, this is the liver, there is a pocket of air. Normally, do we see any pocket of air in between diaphragm and liver? There is no, because can we see diaphragm and liver separately? Do we? We don't. But here we are seeing, that means there is a free gas that is present under the diaphragm. This is very important X-ray. Forget about all the X-rays. Whenever there is a pneumoperitoneum, there will be an air in between the diaphragm and the liver. That is what is seen in pneumoperitoneum. And this classical appearance is seen in cases of perforation. And 1 minute, I'll just connect this. This will be seen in case of perforation. Okay, so this appearance is seen in case of perforation. Yes, it can be named as crescent sign. There are multiple signs. You will get confused sometimes. So I just didn't mention it any sign. Also, if you see that the lower margin of heart or diaphragm will not be seen at this part. If you see this lower margin of the heart, that is also one more clue that will give us towards this the air under the diaphragm. This classical appearance seen in perforation. Very important point that you have to understand is never ever do an abdominal X-ray. You're going to miss the findings, because I'm going to show you one of the X-rays where there was air under diaphragm. See, this is one of the example of the chest X-ray which is showing air under diaphragm. But before this, an abdominal X-ray was done. An abdominal X-ray will always miss the air under diaphragm. So if you do a abdominal X-ray, you will miss the air under diaphragm. Always do a chest X-ray. So that is when we will see the air under diaphragm clearly. So why? Because the chest X-ray parameters are set such a way that air is enhanced. So that's why we see the air under the diaphragm, which will be seen like this. So if we miss even this, then the patient will come in this condition. That's when we can never miss the finding. Very clear air under diaphragm. This air is even up to 1 ml of the air. When it is leaked, we will detect in this erect chest X-ray. So whenever you think of a perforation, do an erect chest X-ray. Whenever you think of a bowel obstruction, do a erect abdominal X-ray. Okay, so what are the other signs that we see? Can we see here the bowel wall? Now if you see here, we can see both the wall of this bowel. Okay, we see this is the bowel wall. We can see the inner surface. Till now we never saw the outer border so clearly. In this image, we can see the outer border of the bowel so clearly. Even of this colon, we can see the outer border so clearly. I told before only, whenever we see the outer border of the bowel, it is a pneumoperitoneum. What we are seeing here is the air. What structure goes here? Okay, what linear structure from the liver goes down like this? What linear structure goes down from the liver, which is delineated by the air right now? So what do you think this structure is? This is not SVC. SVC would have seen like this. And why pneumoperitoneum will not show SVC or aorta? Can anyone guess why pneumoperitoneum will not show SVC or aorta usually? Can anyone guess why pneumoperitoneum will not show on X-ray? Can anyone guess? Good. It is retroperitoneal. Avinash Mukherjee has got it. It is retroperitoneal. Pneumoperitoneum is anterior to it. It will not come and sit in between the aorta and IVC usually. So that's why it is usually not delineated and seen. Okay. In a pneumomediastinum, sorry, retroperitoneal air, we will see sometime. We might see it. It is not a classical condition, but we might see it. Is that portal vein? This is not portal vein because liver is somewhere above this level. It is not even here. It is somewhere above this level. Something that is going below the liver, almost towards the umbilicus. Good. Who had got it? If I can't see it now. PA1 has told that it is because of a falciform ligament. There is a membrane, falciform membrane, attached from the abdominal wall to the liver. Normally, it is abdominal wall and liver are touching to each other. The falciform ligament is somewhere in between all these soft tissues. We cannot delineate. You get the air that pushes the abdominal wall out, liver back, and you can see that the membrane there is seen as this falciparum ligament, and ligament of Teres is a horizontal ligament, so it might be seen as a round structure, but this is a linear structure from up to downwards. So this is a falciparum ligament. What we see here, fibrous band, IPAD 6, good, but what fibrous band it is? It is falciparum ligament. Okay, now if you see this, what we can see in the children, sometimes we can see this large abdomen with liver. All the surfaces of the liver is delineated. So whenever we see any surfaces, just think, will I always see all the borders of liver? No, because up it is continuous with diaphragm, side it is continuous with abdominal wall, but sometimes the paracolic fat, sometimes retroperitoneal fat will delineate the liver from the lateral abdominal wall, but not from the liver surface or superiorly. So whenever we see all this, whenever I see the outer border of bowel, whenever I see outer border of liver, whenever I see inner border of abdominal wall, think that there is air. So whenever you see good, it is called football sign, because American football is nothing but rugby, what they call. It looks like this, so it is called football sign. Whenever in a child, when they suspect necrotizing enterocolitis and they are telling bowel is the abdomen is distended, you don't even have to do an ultrasound. Just do a lateral X-ray of this baby. We will see air within the pneumoperitoneum. Very simple diagnosis. Even ultrasound might be difficult to pick up. So again, here showing the wall, outer wall of the bowel, seen very clearly. Now, what is the structure? Last 3 to 4 slides. Come on, it's for you guys. What is the structure? What structure is seen here? So what do you think is seen here? So what is this structure that is seen here? Good, IPAD 6, it is saying. Got it right. Good, Pa got it right. Rahul got it right. See, look at the density, almost the density or more than the density of the bone. So that means that it is something that is as dense as bone. It is a calcium, made up of calcium. It is a calculi, renal calculi. And this kind of calculi in the kidney is called Staghorn calculi. And what is seen in this image is, again, you can see this is where the kidney, so this is where the area of the kidney is. So we can see some cal here, the dense structure here. This is again the calculi. Now, one more very good example here. What is the diagnosis here? What is the diagnosis here? Okay, this is for you guys. I'm not telling all these answers. What is the diagnosis here? Okay, this is what I have not taught you. Just search for. Yes, there is a bladder calculi, vein stone, proteinuria. Sometimes you'll see this is a bladder stone. Good. What are we seeing here? What are we seeing here? What are we seeing here? Boo. Okay. What are we seeing here? Lake of Chain. I can't see any lake of Chain, but good, it is pancreatic calcification. Good, it is pancreatic calcification. See the density, just relate it to the structures there. One more example of calcification. Again, what do you think is this? Okay, anyway, today was a class on the X-ray radiograph, and so that's about the X-ray radiograph. If you have to good, it is Apple Core appearance, not string sign. Anyways, it is for next class, some other class. So what you have to understand is metal, bone, soft tissue slash water, fat, and air. These are the densities that is seen in X-ray. Always look for air in abdominal X-ray. Also, outer border of any structure without air should not be seen, and a small bowel obstruction. Always do an erect abdomen, and a perforation. Always do a erect chest X-ray. If you have understood so much in this class, all that I have taught is of some help.